Welcome to the 2022 CJD Foundation Virtual Conference. We're pleased to present an update from the National Prion Disease Pathology Surveillance Center. First, we thank our conference partners, the Centers for Disease Control and Prevention, and the National Prion Disease Pathology Surveillance Center. And we thank our supporters. Thank you to all of you who support through donations to the CJD Foundation and through Strides for CJD. You make programs like the virtual conference possible. We hope you'll join us for our next session on Thursday, July 21st, 7 p.m., an update on the CJD Foundation Research Grant recipients. To register for this session or view any recorded sessions, visit our website. During tonight's presentation, if questions occur to you, please enter them in the box during the presentation. At the conclusion, Dr. Appleby will answer as many as possible pertaining to tonight's topics. Well, I am very pleased to introduce our speaker, Dr. Prion Appleby. He is director of the National Prion Disease Pathology Surveillance Center, and we're fortunate that he's also our medical director at the CJD Foundation. Our community is so thankful for the work of the National Prion Disease Pathology Surveillance Center, from surveillance to testing to research. Their work and their tissue bank and their collaboration with researchers is really vital to exploring and monitoring prion disease and to helping advance the field. Dr. Appleby in particular is tireless in his support of families affected by prion disease and in his support of us at the CJD Foundation and all of our programs. So it's my pleasure to introduce Dr. Prion Appleby.
Thank you for the introduction, Debbie. Again, we really appreciate being able to give an update to the families regarding the National Prion Disease Pathology Surveillance Center. For those of you who have watched these presentations in the past, it will be a little bit redundant, but I have taken care to have some novel things introduced, so hopefully it's not too redundant for those of you who have attended the conference before. So as an overview, we'll review the purpose of the Surveillance Center for those of you who aren't that familiar with it. We'll describe some of the activities that we do, provide an update of what we've been doing for the last year, and then also describe some future goals of what we're doing. So I'm very happy to say that this is the 25th year that the Surveillance Center has been in existence. We started in 1997 at Case Western University in response to variant CJD, which was caused by the mad cow disease outbreak in the UK, then transmitted to humans in the form of variant CJD. So CDC definitely wanted to perform surveillance activities, and they wanted neuropathologic surveillance. So in collaboration with Dr. Pierluigi Gambetti, they helped fund and start the National Prion Disease Pathology Surveillance Center. So the neuropathologic surveillance activities are entirely funded by CDC. And if you listen to Dr. Ryan Maddox's talk from the CDC earlier in this conference, you heard that there's a lot of synergy between the two of us. And that's because they really are our direct partner and they're our funder. The reason why they want to have neuropathologic surveillance is because it's the only way to definitively diagnose prion disease, which is really important when you're trying to count the number of cases. Perhaps even maybe more important is it also is the only way to definitively tell what type of prion disease it is, whether it's sporadic, genetic, variant, or maybe even iatrogenic. So what this allows for is the neuropathologic and biochemical surveillance also for novel forms of the disease. So we talked about the ones that we know about, but there's always a threat that perhaps there may be new prion diseases. And of course, in our country, we're concerned that this may happen with chronic wasting disease, which makes surveillance especially important for us. So again, the important focus, as you would expect from something that's funded by CDC in the form of public health, are preventable forms of prion disease. And of course, that includes variant CJD, medically induced or transmitted CJD, and of course, any novel acquired prion diseases, such as if chronic wasting disease were to be transmitted to humans. So this is very similar to a graph that I believe Dr. Maddox showed in his presentation. So it's important to remember that CDC does surveillance of prion disease using a variety of different data. So they start with death certificate data through the National Center for Health Statistics, and that's where the physician puts on whether or not the patient died of CJD or something else. So they grab all those data, and then they match it to what is available at the Prion Center. And of course, there could be a variety of different data available at the Prion Center. It could be in the form of an autopsy, but it could also be in the form of some type of clinical testing, whether it be spinal fluid testing or genetic testing on blood. So if you take 2015 as an example, these are all the cases of verified prion disease in the country. And all of them were matched with the National Center for Health Statistics and the National Prion Disease Pathology Surveillance Center. The ones that were only found at the Prion Center are in yellow, so 51. And the ones that were only on death certificates were at 111. Everything else had some matching with death certificates and surveillance center data. And I believe Dr. Maddox said in his talk that about 85% of all cases of prion disease that they know about somehow do travel through the Prion Center, whether it be through neuropathologic examination through an autopsy or through clinical testing. And that's important because that means that we're getting good data. Now, of course, this map unfortunately gets more and more involved every time I show it. But this is the map of chronic wasting disease affecting North America. As you know, chronic wasting disease is a disease of what we call cervids. These are deer, elk, moose, and caribou. And unfortunately, unlike a lot of other animal prion diseases, it's very easily transmitted amongst its own species. It gets excreted in the saliva and the urine and the feces. And of course, these are free-ranging animals. So they're not like domesticated cattle where you can herd them and call them if they're ill. And of course, if they're secreting prions in the way that I mentioned across the environment, that means they're contaminating the environment too. So of course, one of the major focuses of the National Prion Disease Pathology Surveillance Center is to determine whether or not chronic wasting disease can be transmitted to humans. Now, one way to do that is to look at primary transmission between deer to humans, but I think we increasingly have to remember that it may actually occur through another avenue. So we do know that other animals can potentially get chronic wasting disease, and it may be that it's very difficult or impossible for us to get chronic wasting disease from deer, but it may be much more easier to get it from another animal. So just an example, earlier this week, there was an article by Dr. Debbie McKenzie's group in Canada that had an animal model that showed that beavers are potentially at risk of being transmitted chronic wasting disease too. So again, you know, that's kind of a complex situation for surveillance. Is not only are you looking at what you know is a risk through deer, but you also have to look at maybe unknown risks of other animals that may be harboring the infection. It's a very complicated. So one may ask, well, if you do neuropathologic surveillance, and we know that variant CJD looks very different from other forms of prion disease neuropathologically, how do we know whether or not chronic wasting disease would look different from other forms of prion disease? And the answer to that question is what we would call historical controls. And what that means is, again, having been in existence for 25 years, we've collected a fair number of prion disease cases. We know what they look like, and we can categorize them. And one way that we do that, especially for sporadic CJD, is by what we call molecular subtypes. And I'm going to describe to you how we do that because it's actually quite important to understand, especially when I show you data later on. So there's two factors that go into making a molecular subtype. The first factor is genetic. So we all have a prion protein gene that generates the normal prion protein that we all make that all has a function in our normal body. There's amino acid at position 129, also called codon 129, where you have normal variation, meaning that all of us have some variety of that. And you can either have a methionine or a valine at codon 129. Now, of course, you inherit two copies of the prion protein gene, one from your mom, one from your dad. So you could have a combination of methionine, valine, or methionine. Those are your three possibilities. And the second factor that goes into making up the molecular subtype is what we call the prion protein type. Now, prion protein is a little bit unique in that it's very resistant to digestion. So if we take protease K, which is an enzyme that basically breaks up proteins, we put it on brain tissue, all proteins should go away, but prion proteins that cause prion disease remain. And what we can do is we can do what's called a Western blot that looks at the size of those fragments of protease-resistant prion proteins, and we can look at the size of them. So in this graph, this is an example of a type 1 and type 2 prion protein. You'll see that the type 2 prion protein is a little bit lighter, at least this third band is, compared to the type 1. So getting back to molecular subtype, we take those two factors, the codon 129 polymorphism, MV, or VV, we combine it with the prion protein type 1 or type 2, and it gives us 6 different molecular subtypes of sporadic CJD between MM1 to VV2. Now that's very important because we know what they look like. They have very distinct features biochemically on the Western blot, on neuropathology when Dr. Cohen looks at the histology slides. And they also very frequently have very distinct clinical distinctions between the two, between all of them. And I'll show you an example of this later on. So we did this last year, and I think it was helpful. So I want to do it again. And that is, what goes into a final autopsy report? So unfortunately, we do know that you guys have to wait a long amount of time to get your reports, and we really apologize for that. Of course, some of those things are not in our control. Sometimes it takes a while for us to actually get the tissue from the providers. And then sometimes actually we send out the report to the physician and there's the delay in the physician giving the results to the family. But there is also a delay within the center itself because of what we do in order to achieve a final autopsy report. And one thing I really like about the way that we do autopsies is there's a lot of checks and balances. Now that's a double-edged sword. It has its pros and it has its cons. The pros is we can be pretty sure that we're giving you the most exact data that we possibly can. The downside is when you do so many different analyses, you're bound to have some incongruencies. So of course, we want to address those incongruencies, and sometimes that takes time. So I'm going to take you through right now everything that we look at when we do a final autopsy report. And as an example, this will be a patient that had sporadic CJD of the VV2 molecular subtype. So the first thing we do is we look at clinical history. Some of this we have because of the consent form that you guys fill out for us. We appreciate you doing that for us. And then sometimes we also get medical records from the physicians of the patients. And we look at things like age and duration because they can differ quite widely between different subtypes. We look at the clinical presentation and whether or not there are any known acquired prion disease risk factors like cadaver human growth hormone, dura mater, grafts, corneal transplants, or suspected or possible risk factors, things like being a venison consumer or a hunter, things that we don't know for sure that it can transmit prion disease. There's no evidence for it, but it's certainly something that we're tracking. So in the case of this VV2 patient, they should have an age that's pretty typical for sporadic CJD, midlife to late life. They should have a duration that's pretty typical of the mean duration for sporadic CJD of about 4 to 6 months, maybe a little longer. The clinical presentation usually is actually quite specific in BV2 because BV2 really affects the back part of the brain that does balance, something called the cerebellum. So they very typically have a lot of cerebellar symptoms earlier in their disease course, like gait imbalance or incoordination of the extremities. And then, of course, they shouldn't have any recognized acquired disease risk factors like what I just mentioned. Then we look at spinal fluid diagnostic tests if we have them, and we do in the majority of cases. Of course, at the Prion Center, we do 1433 tau and RT-QuIC on the spinal fluid. Now for VV2, the 1433 should be positive. The tau should be pretty high. And VV2 almost always has a positive RT-QuIC, and it has a very distinct looking curve. So that's helpful. So we look at those things and make sure that matches with what we would expect for VV2. As you know, we also have a brain MRI consultation program. If we have those MRIs, we'll look at it. VVT also has a very distinct MRI profile where just the middle part of the brain, the basal ganglia, are typically bright on MRI, so that should match. We look at the Western blot, what I showed you earlier. So this is another example of a Western blot with a patient sample. You have the type 1 and type 2, which is your reference. And then we have brain tissue from the frontal lobe, the occipital lobe, and the cerebellum in this patient. You can see that their protein lines up with type 2. Now, I apologize, this is not from a BV2 patient, or else you would see a lot more cerebellar protein than what we see here, which is none. But you get the example of what we're doing when we're looking at a Western blot. Then we do two types of neuropathologic examinations. This is what Dr. Cohen does, our neuropathologist. The histologists do two types of stain. The first one is called H&E staining. And what that is basically looking at is the morphology of what the brain tissue looks like. So you can see an example of that here. The brain tissue is this pink, and then you can see that there's these holes or vacuoles within the brain tissue. That's what gave rise to its original form of a spongiform encephalopathy. And then the histologist will take the brain, they'll treat it with protease K like we do with the Western blot, and then they'll put a stain or an antibody against the prion protein. And if protein still exists, you'll see these brown deposits. Now, what Dr. Cohen is looking for is whether or not the pattern of the histology matches with what we'd expect for BV2. So we have to make sure that lines up. Of course, the genetics, there should be no mutation. And of course, they should be VV for their codon 129 polymorphism. So that's a lot of things that we're checking. And again, when you check that many things, it's not uncommon for them not to always match up perfectly. So if they don't match up perfectly, we go back and we try to find an explanation for why they're not matching up. And that may be a variety of things like specimen quality. Maybe it was a really long duration case because there was life prolonging measures that was done with the patient. And sometimes that can affect what the brain looks like under the microscope. An example of RT quick, maybe the spinal fluid had a little bit of blood in it, which altered the RT quick profile. So these are all things that we look at. Of course, there's always the potential of a potential mix-up, either on the provider side or our side. So we're able to look at that. If there's extreme disconnect between all these features. But all of these things take time. And of course, sometimes we have to wait for the brain to be ready to do these things. For an example, for the histology, the brain has to sit and fix in chemicals in order for us to do the analyses. So we do say that we try to get the final report out as soon as we can, but it usually takes up to 3 months because we're doing all of these things to make sure that we're giving you and the CDC the most accurate data possible. Okay, so what does the surveillance center do? Well, we talked about the core mission, and that's the neuropathologic surveillance. So that's really the key of everything that we do, but we do a lot of other things in order to fuel that mission. For example, in order to get autopsies, we help physicians make the diagnosis by providing clinical diagnostic tests. We also do outreach and education to help increase awareness of the disease. We sometimes will do specific consultations with physicians. And also we have research. So for the clinical diagnostic tests, we do 1433 tau and RT quick. And of course, we do genetic testing on the brain tissue, but we can also do it on blood, either on patients that don't want to have an autopsy or in family members that want to know whether or not they carry a mutation. We do a variety of outreach and education activities. A lot of this is in conjunction with the CJD Foundation, which has been an excellent partner for this. A lot of times they'll help coordinate grand rounds of neurology, medicine, psychiatry, or even mortuary services. We try to get as many publications out there as possible, of course, research publications, but as much review articles as well and chapters. We try to improve our internet as much as we can, our website. And then, of course, we work with key partners like CDC and the CJD Foundation. Now, sometimes one of the best way to do outreach and education is one-on-one. And we do that sometimes with physicians that call the center. They have questions about the spinal fluid testing or the MRI. And that's an opportunity for us to raise awareness. A lot of times we work in conjunction with the state public health departments in their specific cases. Of course, we have the MRI consultation program where a family or a physician can send us the MRI, and our neuroradiologist, Dr. Beasy, will read it and send a report back to them. And then I also have a clinical longitudinal study called TAP-CJD, where we do remote visits. It's a research study, but it often helps the families kind of understand what's going on with the illness And we're always willing to speak to the patient's physicians as well if they would like to discuss the case. And then we have research, as you can probably imagine. A lot of our research is, just properly characterizing all these cases so that we know exactly what we're looking at. But of course, we always want to improve diagnostics because that helps us improve counting of cases. And when we collect so much tissue and fluid on these patients, it really is our obligation to provide these specimens to other researchers the further the field. So we also act as a research platform in that piece. And then we do have a lot of faculty at the Prion Center that also have independent research programs that are not directly tied to the Prion Center. So I mentioned my teleneurology assessment program for CJD, Dr. Zhao, and I believe this started out as a CJD Foundation grant. He started doing RT Quick on skin of prion disease patients and now has moved that towards Parkinson's disease as well. Dr. Cowley is an associate director of the Prion Center. He's very interested in looking at prion disease and other co-pathologies that go along with it, like chronic traumatic encephalopathy and Alzheimer's disease. Dr. Kong has a variety of chronic wasting disease related projects, often using animal models. And then Dr. Shetty uses copper number variants in prion disease to look for explanations for things like whether or not that causes an earlier age of onset or increases the risk of prion disease. And that also was one of this year's CJD Foundation grant. Another CJD Foundation grant this year came from Dr. Jamie Nuguez, who's trying to optimize spinal fluid RT Quick and improve diagnostics modalities in that respect. Okay, so now I'm going to provide a quick update on the Prion Center activities in the last year. So this is a involved table, but it's really kind of the crux of what we do. So these are all the neuropathologic cases that we've examined. Now we go all the way back to even before 1997, but just to make it somewhat readable, I cut it off at 2001. What you'll see here, these are all the brains that we received. These are the total number of referrals by year, how many wound up being prion disease, and then subdivided by sporadic, familial, iatrogenic, or variant CJD. So sometimes it takes a while for us to get the tissue and get all the analyses completed. So I'm going to use 2020 as our example because, believe it or not, we're still actually working on some 2021 cases because this is based off of the year of death. So for 2020, we received 364 brains, 252 of them were prion disease. And as you would expect, the majority of them were sporadic, followed by familial. And then we had one iatrogenic CJD case. Now, we think that the majority of risk of iatrogenic CJD has been removed. But the problem with prion disease is there's a very long incubation period. That's the time that someone's exposed to prion disease to the time that they develop it. So we still see cases of prion disease where the exposure is 40 plus years ago. And that was this case. This was a case of someone who received human growth hormone from a cadaver more than 40 years ago. And they just presented with CJD and passed in 2020. Importantly, again, one of the main missions of our center is classifying and finding variant CJD. We've only found 4 cases. All of them were thought to have been acquired overseas, and we haven't really had one since 2014. But again, it's important to keep looking because of these long incubation periods. I mentioned down here, we look at sporadic and we talked about the different forms of sporadic CJD, but there are 2 other sporadic prion diseases that are not super common, but we still follow them. And that's variable protease sensitive prionopathy, of which we have almost 80 cases to date. And then basically the sporadic form of fatal insomnia, which we have 37 cases of, which is more than anywhere else in the world. And these are important cases to collect and know about for research endeavors. Now, one could ask, if we're looking for chronic wasting disease, we assume it's going to look different on brain pathology. That's why we're doing autopsies. But what if it's not? What if it looks like another type of known sporadic prion disease, like MM1 or BV2? Well, one way that we can do that, of course, is to count the number of cases, but it's not uncommon for these transmissions to have low transmissibility rates. So you might not see a huge increase in numbers at the beginning of a transmission event. So you can't rely on that alone, although you should look at it. So another thing that we do is we look at the different subtypes and we see if the percentage of those subtypes differ by year. So that's what this is for 2021 and 2016, 2011, 2006. So these are the percentage of these subtypes each year. And they're pretty much the same. There's a little difference in MM1 because we did change the way that we did combined subtypes where you can have type 1 and type 2. So that explains that. But everything else is pretty much in relation to what you would expect with normal variation. The other thing we look at is age. So age, for reasons that we don't understand, is very important for acquired prion disease because younger people tend to be more predisposed to the acquired forms like variant CJD and iatrogenic CJD. So it's possible that chronic wasting disease, if it were to transmit to humans, could actually result in younger cases. So then we're also looking at the average age of these prion disease cases, and they're about the same overall. And again, about the same also, even within disease subtypes. So that's just an example of a couple of different things that we do to look at abnormalities or to look to see if there are abnormalities in these cases. So this is a graph that looks at the number of cerebral spinal fluid specimens that we received every year. So as you can see, we get a lot of spinal fluid specimens. I'm going to call out a couple instances here. One is 2014 is when RT-QuIC was made available through the Prion Center. And then when the CDC updated its diagnostic criteria to include RT-QuIC, we started reporting RT-QuIC on all samples. Now, before that, we were getting about a 10 to 15% increase of samples every year. After that, it actually increased a lot more because, again, thanks to the help for the CJD Foundation, I think the awareness of the power of RT-QuIC has really gotten out there to physicians. Of course, you see the dip with the COVID-19 lockdown. I showed this last year. There definitely was a decrease in the number of samples that we got during the lockdown, and there wasn't really a reciprocal increase after that. But it looks like that we have recovered from that. And if we're at that halfway point now, we're looking at approximately 7,000 samples that we would have received this year. One thing that we can do now that RT-QuIC is part of the diagnostic criteria and it is so specific, meaning that it's really rare to have a false positive, is you can use that in counting cases. Before, we couldn't really do that unless we had an autopsy. So this is the number of RT-QuIC positive cases that we've had every year. So these are almost all certainly prion disease. And then we can combine the number of cases that went to autopsy, which we would define as definite prion disease, combine it with RT-QuIC positive cases that did not go to autopsy and get this combined probable definite prion disease cases based off laboratory-based diagnoses. And when you look at that, then we start getting much closer to the numbers that Dr. Maddox showed in the CDC. So really RT-QuIC is a powerful diagnostic test, of course, but I think it also is a very powerful tool for surveillance as well. We receive blood for genetic testing. You can see that that's been fairly stable over time, although there is a trend for a decrease. That is probably because there are other places that are offering genetic testing for the prion protein gene, which is a little bit unfortunate. One of the nice things about the Prion Center, it is kind of a consolidated center for all things prion disease. So we do lose some data when that happens. But we still do get, I think, the majority of genetic testing done through the center. These are the brain MRIs that we've received over time. You can see that with the foundation's help, again, we certainly get a lot of MRIs, and the vast majority of them are suggestive of prion disease. Again, we get all these tissue and then we share them with researchers. So in 2021, we shared a total of 604 specimens. Of course, the majority of those were brain specimens, but we also shared a variety of other specimens for research. And then if you look at the breakdown of researchers that received specimens from us in 2021, most of them are American, but we do also collaborate with international researchers as well, such as Canada in 2021, but we've collaborated with Australia and with the UK as well as Italy and other countries. So it just differs by the year. And then, of course, we have a variety of different research publications that we do. On the left here are basically publications from last year that we looked at, really trying to characterize specific cases to help with surveillance, but also to help with things like diagnosis and for classification. And then 2021 was really the year of VV1 for us. It's partially my fault, I think, because I've seen a couple of VV1s lately, and they're just a very strange prion disease in that they affect sometimes extremely young individuals. And these are people that, after myself seeing them and talking to the family members and knowing that there really are not any recognized acquired prion disease risk factors, it's really kind of hard to explain the sporadic nature of them. So myself, as well as Dr. Callie, have really taken more of an interest in this subtype and hope that we can have a better explanation, and maybe that helps explain other forms of sporadic CJD a little bit better than what we currently have. So I'm going to end with some future goals of the center. We're going to, of course, continue our neuropathologic surveillance activities. We really want to streamline our clinical testing operations. We kind of have to at this point because of the number of specimens that we receive. So we are now doing automation where we use something called a Bravo that will pipette things automatically for us. This will probably allow us to do more RT quick runs. Now, we're always going to be somewhat limited because RT quick does take 60 hours, but also it takes time for the specimens to get to us. But we do think that this will speed up the ability to get test results out. So we definitely want to try it. And hopefully we can start this at the end of the year or maybe beginning of next year. One thing that's very exciting that we've wanted to do for a while, and with the help of Dr. Shetty finally did just a couple months ago, is we moved the genetics laboratory actually into the Prion Center. So before it was done with our associated hospital, but now we're doing it. And that has a lot of advantages. Number one, potentially we could do it a lot quicker, but it also allows us to do a lot of more high-tech genetics that can really be helpful for things like research and surveillance. And you're going to hear about that in Dr. Shetty's talk, I think, on Thursday. Of course, we're always going to do more education. We especially want to target morticians and funeral directors. So we've gotten buy-in from a mortician that we've been using for a long time, who's really willing to work with us even more now. And we definitely want to reach out more to those parties. And then very importantly, because we're kind of the reference lab in the US for prion disease when it comes to clinical testing, it really is important, I think, for us to help with upcoming clinical trials and their rollout. So the reason why I say that is because the best way to actually increase the diagnosis of a disease is to actually have a treatment, or to have, the possibility of a treatment through a clinical study. So that's going to help. But we also need to let people know that when they're diagnosed with prion disease, they may actually be eligible for a clinical trial. So one of the things we want to do is when we issue reports on our clinical testing, so we have language on those reports notifying physicians that, hey, your patient may be eligible for a clinical trial. Follow this link to find out more. And hopefully that will increase the awareness of clinical trials, but also increase the ability to get patients who may be eligible for them into a clinical trial sooner rather than later. I think it's important that we do talk about why we ask for increased funding for prion disease surveillance. And for those of you who have not participated in advocacy, you might not know the rationale. So I just wanted to talk about that. You have to remember that the line item that we have for prion disease surveillance is for prion disease surveillance as a whole. It's not just for the center. So that money is used for all of our nation's prion disease surveillance, which includes the CDC activities that Dr. Maddox talked about, and also their funding of state public health departments. And then, of course, it also funds the surveillance activities of the Prion Center. So we usually get about half of that, but it really is used for a lot of other things. And unfortunately, as you saw that map that I showed earlier, there's a need to fund more state public health departments because more states are being affected by chronic wasting disease. I think the last count is 30 or 31 states are now affected. So really, that's kind of a pool on that money is having to, increase more states. And then, of course, around COVID-19, the autopsy coordination costs started to rise. And then after that, pretty much all providers increased costs. And transportation actually is a very big cost for us. And with, the fuel rising prices, that is becoming an issue. So the cost of just doing the coordination of autopsy has increased. But ideally, what I would like to do is when we get to the end of a budget year, oftentimes we see that we're ahead of budget, we're over budget. So in order to make budget, we have to start screening autopsy referrals. So for example, this year, we really had to start screening more the beginning of the summer. And we don't want people to take advantage of our autopsy program to just try to get a free autopsy. To be honest, that very rarely happens. And our autopsy coordinators are great at recognizing that. And we do not do those cases. But, sometimes it really isn't in our best interest to do some of these autopsies, or it's questionable. And if we don't have the funds, we have to decline them. But what I would really like to do is, unless those are situations where it's very obvious that they're trying to take advantage of the opportunity, and it's not prion disease, we don't want to have to screen any autopsy referrals because, again, we don't know what chronic wasting disease would look like in a human. So we really have to take all potential cases. So that's really why we're asking for more prion disease surveillance funding as a whole. So these are the wonderful people that I get to work with every day. These are the staff and faculty of the Prion Center. I wanted to call your attention to a couple of people because it's often helpful to have a face with a name. If you had a autopsy done through the Prion Center, you most likely talked to one of these two young ladies. It's Danielle and Megan. They're autopsy coordinators. If you ever called the surveillance center, you most likely talked to this young lady. That's Benita Hester. If you called a few years ago or you emailed recently, you may have talked to Katie. I also wanted to shout out to Casey, who's our database manager, who really helped me put a lot of these data together. And then I also want to call attention to this Thursday with the videos for the 2021 CJD Foundation grants. 3 of our people got awarded grants. Dr. Zal will be talking about a treatment-related grant. Dr. Shetty and Dr. Nuguez will also be talking about their grants respectively. And these 2 individuals are new to the center for about the last 2 years. They're new to the field of prion disease, but they have very specific expertise that makes them very valuable to our field. And this is where I think the foundation grants can be really helpful, is it really provides funds and an opportunity for these individuals to become prion disease researchers, whereas they might not have done that otherwise. So I just want to end with a thank you to all the families and to the CJD Foundation for all your help and support over the years. And I really look forward to possibly seeing everyone in person next year. Thank you.